Okay. So basically what we're looking at, this is me, okay? And we're going to be talking about TMJ, head discomfort, neck discomfort, and how it all relates to one another. Everybody usually talks about systemic situations, joint dislocations, et cetera, but this is a part of the world that most people have the most trouble with, but believe it or not, it's not addressed a whole lot. So this is my disclaimer. Okay. But one thing you should already know, but the basis for your TMJ varies from patient to patient. My classic is I've got 3 sisters, same father, same mother. One daughter, no problem. Second daughter, moderate problems. The third daughter's in a wheelchair. So depending on where it is, and I'd like to liken this to vegetable soup. Some people have more corn, some people have more carrots. Everybody is a little different when it comes to this. Now, the one thing is the treatment prescribed by another patient, while appearing the same, should be tested with the conditions and with the doctor's approval, and stay within the parameters of the management, please. Now, this lecture is going to cover anatomy, and this is going to be almost like a anatomic restoration of what you might know and what you don't know. But we're going to talk about arthrokinematics, which is the actual motion of the joint, patient conditions, pain referral patterns, and we're not going to hit on the management and treatment protocols because we just don't have enough time today. But we're going to give you an idea of what's going on. Again, parameters. Now, the one thing we're going to talk about that you probably never heard about is there's this thing called cervical myofascial pain syndrome. And basically what it does is it links together 3 or 4 different situations. We're going to talk about that too. Here we go. Now, what is a TMJ? TMJ basically is the joint that articulates your jaw to your skull, okay? So what happens is there's a piece of cartilage in there, and there's muscles that suspend the jaw to the skull. They go from your temple, they go from the lateral side of your jaw, behind the angle of your mandible, and then into the joint themselves, and that's what allows the jaw to move side to side. But keep in mind that everything in your head that you see are all closing muscles. The openers are actually under your chin. So when you look at somebody and you're trying to figure out what's going on, normal rotation for a mouth opening is 33 millimeters, and that's where the rotation just rotates inside the joint. And when you open wider than that, the joint will actually translate. So what I usually do is have everybody put their fingers in front of their ears and go ahead and open. Normally, when you open, the condyles of the head of the jaw are going to move out a millimeter, millimeter and a half. That is normal motion. Because the one thing they told you about, they didn't tell you about, is the fact that this joint is actually shaped like a V, okay? So when you open, you actually track out in that V, and that's what makes it move laterally. Now, if it doesn't move laterally, the piece of cartilage that lives in there is usually displaced. Come and see me, you're dislocated, okay? All righty. Now, the one thing also, when you're looking at somebody and they open their mouth, the jaw usually deviates to the affected side, to the side that's dislocated. You won't have any sounds, you won't have any cracking, you won't have any popping. And the condyles, again, displaced to the side. Now, the one thing that people don't realize is that your hip can sustain 200 PSI of load. Your jaw actually will generate 600 to 800 PSI. So if you're going to have a problem, you're actually going to amplify it for the big time with the muscles and the bones and the joint itself. Now, the symptoms that you will see with somebody that has a TMJ problems, you're going to have mouth aberrations. In other words, you're going to open, you're going to go to the affected side, the jaw will hesitate. The limitation of opening will be limited. Most of the time when you have a dislocation of the condyle or the condyle or the cartilage itself, the opening is less than 33 millimeters. Okay. Now, also, people have their jaws locked open. In other words, they go beyond the end of the joint. They lock closed. They're caught behind the cartilage and actually can't do that second phase, which is translation. And you have tenderness, but headaches are one of the biggest things we see. We talked about the muscles on the lateral side of the head, which we're going to see in a minute. And those muscles are actually dependent on the length that they maintain. So, we're also going to talk about abnormal motion. I love this picture. This guy looks like he just came out of a bar fight, but you know, it's Again, we're talking about limitation of motion, the deviations, the pain with motion, the joint sounds, and the displacement of the condyles. Now, this is what we were talking about by what actually will generate the pain in the joint itself. Now, the thing that generates most of the pain in the TMJ are the synovial membrane. And there's actually 4 synovial membrane in this joint, okay? Anterior, posterior, superior, and inferior. And when that piece of cartilage displaces, and that's that big wing thing in the center, when that displaces, that cartilage will actually allow the synovial membrane to be compressed. Now, the area in 7 and 8, there are nerves in that area. That's what's called the posterior laminate. And when that gets compressed, that actually will make your ear itch, make it feel like you've got pressure or fullness, because the same nerve that goes to that position goes to your ear canal. So a lot of times you'll go to the ENT with ear pain, and guess what? It's your joint, not this. Now, the arthrokinematics of the joint basically are the motion of the joint. This is what they call a gangliomo-arthroidal joint. It rotates and it slides. It does both, okay? And as we talked before, it goes in a 3-dimensional pattern. So it'll displace downward, laterally, and anteriorly, okay? So the one thing that we're actually going to talk about that probably is the most pertinent thing on this slide is that the pre- and post-vertebral musculature determine the jaw position. In other words, where the muscles in your neck are, am I humming? Okay, will determine your jaw position. Also, the craniomandibular rest position is a function of the mandibular rest position. So in other words, where the jaw is determines where the head is, and where the head is determines where the jaw is. It works back and forth. Now, we were talking about the muscles anatomy that will actually generate a headache for you. Basically, what happens is the big orange muscle on the side of your head is the temporalis muscle. And that is the one that will give you, quote unquote, the tension headaches. And basically what happens is the way the joint is built, there's a piece of cartilage in between the jawbone and the skull. It actually gives you 2 to 3 millimeters of spacing. Okay. When that cartilage displaces, in other words, locks your jaw closed, the whole mandible will move up. And when it moves up, it allows that temporalis muscle to actually shorten and spasm. So if you close and squeeze your teeth together, a lot of times you can actually feel a muscle rippling in that lateral temporalis muscle, and that's usually where you get your headache, believe it or not, okay? Now, the masseter is the muscle inside of your cheek, and that's the one that will make your teeth sore. I don't know if anybody's ever been to the dentist and they say they've got this molar that's killing them. They end up doing a root canal, they do a crown, they end up taking the tooth out, and the area still hurts. Well, the problem is it's not the tooth. It's the muscle referring pain into it. It's called myofascial pain referral syndrome, okay? The internal pterygoid is the muscle that's underneath the angle of your jaw, and that'll give you tightness there. But the one that gives you the most fun is the external pterygoid muscle, and that's the one that allows you to move your jaw side to side. And that actually has 2 heads. The superior head goes to the piece of cartilage, the inferior head goes to the condyle. And that's the one that gives you the sharp zip into the joint every once in a while. Now, there are other muscles. The opening muscles are the inferior muscles underneath your chin. It's your anterior belly of the digastric, the omohyoid muscle, the superior and the middle pharyngeal constrictor muscles. And we're going to talk about those because they are more than pertinent when it comes to referral pain from your jaw to your neck and back and forth. Now, these are the muscles in the posterior part of the head. Remember, we talked about how the position of the muscles of the neck determine the jaw position, and how the jaw position determines the neck position. These muscles are actually affected, and these are the muscles that are actually infused when you do a migraine Botox protocol. In other words, these muscles have to be relaxed. Now, I don't know if anybody here has had a spinal fusion, but these muscles are actually taken over the top of the fusion, the titanium, et cetera, and what we usually have to do 6 months after you have the surgery, we actually have to infuse these muscles with Botox to relax them because they're going to generate pain into themselves. Now here comes the neurology. Everybody loves this. The nerve that runs your muscles in your jaw, your teeth, your sinuses, everything from your eyebrow down is the trigeminal nerve. largest nerve in your head besides your brain, okay? And it has three major branches, V1, which is the notch in your eyebrow, V2, which is the notch under your eyeball, and V3, which is in your mandible. V1 and 2 are sensory, V3 is sensory and motor. But there are some other areas that people don't realize. Number one, they all go to the muscles of mastication, we know that, but it also goes to the area under your chin. But what happens is it'll actually go to the lateral rectus muscle in your eye. So when you end up with jaw pain or headaches, it's not unusual to have problems with your vision and or double vision because it actually goes to the muscle that abducts your eye. It also goes to C2 in your neck, believe it or not, and goes as far as L2 in your lower back. So pain in your upper neck and back can actually generate pain in your lower back. Now there's a couple of mechanisms that we should probably know about. Number one is nociception. Nociception is the source of the pain is one place and the site of the pain is someplace else. The classic is pain in the lower portion of your anterior neck, which generates the source in the lower portion of the anterior neck. The pain is actually, the anterior portion is up in your forehead. That's the source of pain is one place, the site of the pain is someplace else. But the one that really keeps us going is the thing called convergence mechanism. Now, I don't know if anybody's heard the fact that the more you clench your teeth, the more your airway closes down. What does that mean? Well, basically, we're going to see in a minute, there's a muscle called the superior pharyngeal constrictor, and it's medial to your masseter, which is in your cheek. The more you clench your teeth, the more it activates the superior constrictor, and it will actually close your airway down by 50% as you close your teeth in your sleep. You can clench. Now, we're also going to talk a little bit, nothing exciting, but cervical cranial instability basically is the position of your neck and the position of your head. The biggest thing I can tell you is the more your head tends to come forward, like when you're looking at your iPhones or looking at your computer, it'll actually double the weight of your head. So what it tends to do is it tends to strain the ligaments, the tendons, and everything that will maintain your head in position. Well, there's muscles and nerves that come off of that, obviously, and the nerves that actually give you the most fun are what they call the occipital nerves. The head position and the constriction of that occipital nerve will actually give you pain up the back of the head, and believe it or not, over the eye. And we're going to actually talk about that in a minute, too. We're talking about if you're born in flexion, we've got to straighten you up a little bit. So C2, I don't know if everybody knows what the deal is, but C1 is the vertebrae close to your head. It is a big washer. The kid that runs all the entire show is C2. It has a dens, a vertical protuberance, which actually directs the position of C1. So what tends to happen is that if C2 rotates to the right, the dorsal process will go to the left, and et cetera, et cetera. If there's a permanent displacement of that process, that's what limits your head turns. So if you're standing there looking at somebody and you can't turn your head to the left, chances are that vertebrae is turned to the right and the process to the left, and that's what's limiting your head turn itself. That will also cause the generation of the headache. Now, the one thing we're going to see here in a minute that rotation of C2, believe it or not, will actually cause distortion of the mandible. Yeah, you wonder where I was going with all this. Basically, what happens is that when C2 rotates, it'll actually take the mandible and distort the position of it. And that's when you get the popping on the same side as the limitation of the head turn. And we're going to see that in a minute also. Now, this is what we're looking at. The X-ray on the left, you see where everything is balanced. You see the midline, you see the two areas to the left and right, and you see the lateral process. What you're looking at is the dens, the vertical portion of C2, and you're looking at the spacing between C1 and C2. Everything is balanced at this point. The center X-ray is a rotation of the C2 to the right. You see where the space increases to the right, but look at the bite height, the molars in the rear. You see how they're higher on the left than they are on the right, the red line. Same thing happens with the other side, the last X-ray on the right, rotation is to the left. You can see where the bite height is lower on the right. Believe it or not, the jaw actually changes position when the neck changes position. This is my kick with oral surgeons. They'll come in and actually say, well, I can fix your click by surgerizing this. I can fix this by putting your neck back in position in 5 minutes usually, and about 70% of the time without the surgery. A little something to keep in mind. Now there's another testing that we do to keep things going. There's the Atlas testing and there's the Atlas axis testing. And basically what happens is what you're doing is you're looking at rotation of the head, and you're looking at the ligaments that actually suspend the head to the neck. So there's 3 major ligaments. The cruciate ligament, which allows you to look up and down, it's your yes ligament. The transverse ligament, which is your no ligament. And the alar ligament is your I don't know ligament, it's your side to side, okay? So basically what happens when you have limitation and or rotation, those motions will be limited. And that's one way to tell if you've got a vertebral problem. Now I just throw this in here just for grins. What you're doing is actually looking at a skeleton with the mouth open. And if you can see right behind that spring, there's a horizontal arch of bone, okay? And basically that's the anterior arch of C1. That's what makes it so you can't swallow the pills, believe it or not. C2 will rotate, it'll push C1 forward, and that's where the pills get stuck in case anybody wondered, okay? And I just throw that in there just for grins. Now, other things we look at the hyoid bone, the position of that, and the hyoid bone will get higher and go more posterior the more you clench your muscles, clench your jaw muscles. And so basically what happens is the elevator muscles and the muscles that cause the clenching. And certain things occur when that happens. Number one, your upper lip will start to shorten, believe it or not. You'll lose the Cupid's bow in the upper lip. The jaw will retrude, actually, okay? And the superior pharyngeal constrictors, which is what we just talked about, will actually spasm, close the airway down by 50%, and actually your breathing will decrease. And that's when you start getting the AHIs, the apneic hypopneic indexes, and that's what goes up. I don't know if anybody has had a sleep study, but when you have the sleep study, they tell you what the AHIs are. If you're over 30, you usually get a CPAP. If you're under 30, we can usually make an oral appliance that'll help you. But it's just a little piece of information there. We're talking about the forward head posture. We're talking about doubling the weight, et cetera, and we were talking about the cervical angulation, which nobody here needs to worry about. This is a doctor thing, okay? Now there's a situation called torticollis. I don't know if anybody in the audience has torticollis, but basically, right here, it's a physical straightening of the spine. It usually happens between C6 and C7 in your neck and has to do with the rotation. And what happens is the sternocleidomastoid muscle, which are those big turning muscles on the side, will actually go and stay in the spasm, and the spine actually straightens. And when it does, that'll actually cause neural compression. And we talked about the yes, no, and the perhaps ligaments. We've already talked about that. And these are the kids. This is where everybody is. So now we're going to talk about the cervical myofascial pain syndrome. And basically what it is a combination of about 4 different things. So let's talk about the pharyngeal constrictors first. What is that? Those are the muscles in your neck and your throat that when you swallow, they actually constrict and actually put the food down your throat. They actually maintain the tenor of your actual pharynx. The superior pharyngeal constrictor, believe it or not, starts right here at the tip of your chin. It's attached to the orbicularis, which is your kissing muscle, to the buccinator, which is the muscle in your cheek, and it actually attaches to the area behind the buccinator and against the masseter. So when you feel up there, there's a little void right there. And that little void is where that superior pharyngeal constrictor muscle starts. It goes all the way around the back of your throat, comes out the other side. So here's a picture of how it actually goes around the back of your trachea and your pharynx. And so here's the middle pharyngeal constrictor muscle. It goes from your hyoid bone to the C4. So the one thing that you don't understand is that this area right here, the void that we felt, that actually attaches to C1, 2, and 3 in your neck. That actually determines where that is. So if you stick your jaw and push it forward, you can actually feel it pull in your neck, okay? The middle pharyngeal constrictor muscle actually goes to C4. So between here and underneath your chin determines where those first 4 vertebrae are actually positioned. And here's the constrictor talking about how it works in the omohyoid muscle and the middle constrictor. Now I'm going to throw this in, dysautonomia, just because of the fact that there is a structure in the rear of your throat where that superior constrictor goes around. And there's a couple of structures in there that are actually affected by the position of the muscle and what's going on. So here's a horizontal picture. It's gross, I know, but it shows you what's in this area. And this is what's in the area. Gosh, think about this. The vagus nerve, the accessory nerve that goes to your shoulders, the hypoglossal nerve at the back of your throat, sympathetic trunk runs your GI tract, your heart rate, your breathing, the alar fascia that actually positions C2, the glossopharyngeal nerve, again, back of your throat, the internal carotid artery, the facial nerve, all these structures go through that area. So if you have distortion of the superior pharyngeal constrictor and or the position of the head and neck, it's going to affect all these. This is my version of dysautonomia. And the thing I found is that a lot of times this actually affects that. So I can usually tell by your head position how much GI problem you've had. Now, the cervical myofascial pain syndrome, believe it or not, is basically has to do with the position of C2 and C1 in your neck. And that's that limitation of head rotation and the referral pain. So basically what we're looking at is a series of spasms. So there's a muscle called the levator scapulae muscle that goes from C2 to C7. When C2 rotates, the side that it rotates, what it usually does is cause a muscle spasm. And that's the one that goes under your shoulder blade. When you're standing at the sink and it feels like somebody slipped a knife underneath that shoulder blade, it's actually spasm the levator, and that has to do with the position of the C2. And there it is, it's going underneath the shoulder blade. And now, this is all tight, and I'm going to just summarize this for you. But basically what happens is when C2 rotates, C1 usually tracks with it, and that's that knob that you feel behind your ear. So when C1 rotates laterally, what it does is it actually pushes on a muscle called the sternocleidomastoid, which comes from the bone just underneath your ear. Sternocleidomastoid goes from there, it goes to your suprasternal notch above your sternum, and you'll actually have a spasm that tracks there. There's another muscle called the longus colli muscle, which is in the lateral part of your neck, and your convergence mechanism will actually cause that to spasm. So basically what you have is you got discomfort going underneath your back, discomfort coming down the side of your neck. Well, guess what? When C1 and C2 rotate, there's a thing called the greater and lesser occipital nerves. And those are the nerves, the lesser occipital nerve is the one that goes behind your ear, and that's why that's sore. But the greater occipital nerve comes out between C1 and C2, the dorsal processes in your neck, and that actually goes, believe it or not, to the back of your head, to the top of your head, up to your frontalis, and will actually put pressure on that notch, that V1 nerve, and then it'll actually end up going behind your eyes. So, and there's the aponeurosis. That's that white area at the top of the skull. So the pain actually starts at the base of your skull, up the back of your head, over the top, to the frontalis, above the eye and behind the eye. So basically what we're looking at is C2 rotating causing pain underneath your shoulder blade, pain in the lateral portion of your neck, and pain above and behind the eye, believe it or not. And that's where the headache is. So if somebody tells you that they got a headache over the top of the eye, chances are it's coming from the neck, from the greater occipital nerve. Basically, in summary, we always wonder what happened first. Did the jaw dislocate the vertebrae, or did the vertebrae dislocate the jaw? Chicken and the egg situation. And so basically, when you're talking about TMJ and upper cervical stability, the TMJ and upper cervical stability are almost always related in the TMJ patient. We did a survey of 200 patients. 195 of them had TMJ problems. 190 of them had cervical myofascial pain syndrome. So basically, when you look at this, the misalignment will cause vertical torsion, which causes the jaw to deflect and causes all the problems that we're looking at. I'll take